This is a review of the safety considerations on the ACR 2015 RA treatment guidelines. My name is Dr. John J. Cush, Director of Clinical Rheumatology for the Baylor Research Institute. Today I'd like to address some of the safety concerns that were covered in the recent 2015 RA treatment guidelines published last year by the American College of Rheumatology. A lot of the document dealt with treatment decisions based on whether it was a naive patient or a patient with established disease, based on how much disease activity, etc. I won't be discussing those treatment options. Instead, I'm going to talk about the treatment options afforded in the context of specific comorbidities. It first should be noted that in discussing some of the comorbidities, there was no discussion and hence no guidance on what to do in patients who are pregnant. This is something, a major deficit of the document, but also has to do with what will be covered in the future by the American College of Rheumatology as they are going to develop a guideline committee with regard to pregnancy issues in and around rheumatic diseases. They did discuss a number of different safety concerns. It should be stated that for all of these safety concerns, the level of evidence is very low, which means it was basically expert opinion, which is why I'm going to comment on them, because I believe that I have some expertise in this area of drug safety and that my views are not necessarily represented by these. So for both CHF, hepatitis B, hepatitis C, malignancy, skin cancer, and melanoma, lymphoproliferative disorders, solid tumors, and serious infectious events, they make recommendations based on very little data. Specifically regarding congestive heart failure, they say that you should be using combination disease-modifying anti-rheumatic drugs or a non-TNF biologic or tofacitinib. Yet they disregard the need or use of TNF inhibitors, which actually have been studied extensively. And two things have been shown. One, that if you give TNF inhibitors to patients with heart failure and no arthritis, that the outcomes were surprising and unexpected and not necessarily good, meaning that there was a dose-related increase in cardiovascular events and cardiovascular deaths or hospitalizations. However, when you give TNF inhibitors to patients with rheumatoid arthritis and no prior history of heart failure, there was no increase at all in de novo events. Moreover, if you give this to patients who have class 2 or 3 heart disease, there was also no increase. And so the reason that TNF inhibitors were excluded was because of the studies done in non-rheumatoid patients. I'm not sure that's a smart idea to exclude patients from receiving maybe potentially beneficial therapy. I would use a TNF inhibitor in heart failure if the patient had class 1, class 2, and maybe well-compensated, well-treated class 3 disease. Hepatitis B and hepatitis C, again, very little evidence. For hepatitis C, they recommend a DNF inhibitor over a DMARD over a TNF inhibitor, where there is very little sketchy use of DMARDs in patients with hepatitis C, but there are hundreds of patients in the literature showing that hepatitis C can be well managed with TNF inhibition. Hepatitis B, if you have hepatitis B surface antigenemia and then hence active disease, you should not be receiving a biologic. However, if you have an occult infection, meaning that you were exposed in the past to Hep B infection and now are Hep B surface antigen negative and Hep B core antibody positive, with or without B surface antigen antibody positivity, they recommend that you receive a DMARD more so than a TNF inhibitor. Again, hundreds of reports of TNF inhibition being used safely in a situation. They also recommend that you monitor viral loads, something that actually hasn't been studied. Malignancy, for those with melanoma and non-melanoma skin cancer, the evidence again is very low and favors or was recommended use a DMARD over a biologic or tofacitinib. Maybe a reasonable recommendation, but again, it does not take into account the large volume of research with TNF inhibitors. If you have a lymphoproliferative disorder, the evidence is very low and they recommend rituximab or combination DMARDs or abatacept or tocilizumab over a TNF inhibitor, yet many thousands, tens of thousands, even 100,000 patients treated with TNF inhibitors in the setting of lymphoproliferative disorders in the past or currently, and no increase, meaning the rate associated with TNF inhibitors is exactly the rate associated with rheumatoid arthritis, hence it's the disease and not the drug. Lastly, they say if you have a solid tumor, that you should receive the same therapy as you would if you didn't have a solid tumor. I've received many questions this week about patients who have prostate cancer or lung cancer, and can I safely use their previous biologic therapy? And of course you can, and the evidence is actually quite good in that area. And then finally, our one major concern, or maybe our first concern with these drugs, is serious infectious events, or SIEs. Again, the evidence that's supporting the ACR recommendations is very low. They suggest combination DMARDs be used before, or abatacept, excuse me, be used before TNF inhibitors. Again, I think that the most important thing is that inflammation drives infection risk way more than it does a TNF inhibitor. I think infliximab and high doses has a much higher risk than any of the other biologics. I think abatacept probably has the lowest risk of all the biologics, and certainly a combination DMARD regimen is also going to look very good, but that's the comparator group. So again, those are reasonable recommendations, but I don't think I would exclude a TNF inhibitor from consideration. Thank you very much.